folks may be indisposed. Or otherwise, people may be very relieved. I don't know. Maybe this might be the best week ever for folks.
It's slowed down a little bit. I think you're probably good to get going.
All right, so we can go ahead and jump in, and then folks can join in as they so wish. So welcome, everybody. Been a little bit since we last talked. Hope everyone has enjoyed the end of their summer and is enjoying nothing but rain and thunderstorms and getting back to school and all the fun stuff that's going along with that. So there will be a lot of discussion today. I'm sure there's going to be a ton of questions about the bivalent vaccine, state of emergency ending. What does all this mean? So we're going to have several topics to go through kind of all at once, and we'll try to move through them fairly quickly and then get to questions because I'm sure there will be plenty. I'm going to start with probably the least exciting and controversial of the discussions, which is monkeypox. So I think the last time we talked, there had been 7 reported cases in Monroe County, no cases in the surrounding counties. We are now up to a total of 10 reported cases in Monroe County. There's actually 1 in Chemung, and I think by the last time I looked at the grid, which was yesterday, there had been no other reported cases in the Finger Lakes region. There had been some folks who had reached out about concern about a rash of cases in Ontario County. New York State Department of Health is still reporting no cases in Ontario County at this point. So I am not aware of that, nor have I heard any reports of it, but at least one person had asked about that. So still almost a non-issue in Western New York. Certainly there will be some renewed concerns as California has a confirmed mortality from monkeypox that was in a severely immunodeficient individual who contracted it. Texas is reporting a mortality, although that has not been definitively confirmed yet, but also a severely immunodeficient individual. So still remains to date largely a epidemiologic situation amongst what I'll say is seemingly homosexual population and disproportionately in the African American and Hispanic male homosexual population.
Okay.
Which is interesting and not completely clear at this point as to why. I mean, obviously the close skin to skin contact is the transmission rate, but why that is not affecting the heterosexual population even remotely close is still not clear. But nonetheless, I think the transmission is almost a non-issue in Western New York, thankfully. And although there does seem to be, it seems to be more of the health departments having concerns about folks who are just reporting any rash that happens to come up, any pustular rash that Dr. Mendoza had mentioned last time. It's much more likely to be poison ivy than it is monkeypox. So really, it has to be that very classic cratering looking pustular rash to even start the epidemiologic concern, and really should be in that high risk vulnerable population. So with that, I'm just going to segue away from monkeypox because it really doesn't have a lot of other excitement at the moment. And that's all there is to say. And it has not had even the trajectory it did the last time that we spoke, which is great. Now, briefly on to the state of emergency. So as everyone probably has now heard, or if you haven't, you've heard it here first, Governor Hochul announced that she intended to let the state of emergency expire, which I believe is due to expire on September 19th. And that with that, all of the executive orders that go along with that would sunset to some degree. So several things. First question that folks have asked is why? Maybe it's just the non-trusting of the political sphere side of me, but it would be remiss not to at least concede that it's actually a relatively close election for the governorship right now. And the state of emergency is not the most popular thing in the world, and the state of emergency will expire right before the election. So that certainly plays into it, no doubt about it. There are some politics. Number two, if you look statewide, and certainly what Governor Hochul is stating, is that the rate of transmission has remained relatively low. Now it bounces around a little bit, but it in general we've not seen the spike that we saw even a couple months ago. And it does appear that the the rate of infection is certainly a little bit less than even it was a couple of weeks ago if you kind of track the percent positives rate. So, and downstate, that would certainly be true. Third, I think if you look at some of the surrounding larger states, we're starting to see that others are starting to sunset their state of emergency as well. So I do think that this is a little bit of a partnership, if you will. Now, whether it's because everybody knows election season is coming up, I don't know. I don't know if I can say that that's the role, but certainly there are a multitude of factors, but it will sunset. The most pressing thing that I suspect for this group really has to do with what does this mean for masking in healthcare settings, and what does this mean for telehealth coverage? So I'm going to start with the masking. As of yet, the masking in medical arenas is unchanged. And so that will not be affected by this. So that I do not think will be affected by the sunsetting of the executive order. However, the telehealth parity would theoretically be vulnerable. We have, in fact, just as recently as a couple days ago, had conversations with Excellus. Excellus does not perceive that this will affect. In fact, we just got an email earlier today that they do not perceive that this sunsetting will affect the parity for telehealth, at least in the short term. As we had talked before, the kind of agreement that we had with Excellus is that I think it was 90 days. We're trying to verify exactly what that was, but that they would give us a window of time, even after the sunsetting took place, before they would make any policy changes in their coverage. However, there are two bills, one in the House and one in the state legislature, that are looking to create a parity reimbursement structure that will be enduring as law. And so the anticipation is that either or both of those will get fired up as we start to see the states of emergency sunset. Now, granted, the federal government is not suddenly going to respond because New York sunsetted their state of emergency. But as I said before, there are other large states that are also sunsetting their state of emergency. So there is going to be a larger proportion of the country where telehealth parity may be preserved at the moment, but may not be at the sunset of the public health emergency, where the federal law could be useful. So I think there are many avenues, and there seems to be general support for telehealth parity being sustained for the duration, but we are not vulnerable in the short term at this point. And if everything holds true, I would largely suspect no matter what happens, we should be preserved probably at least to the end of the year. But we'll continue to follow this. We'll continue to update you guys if we hear of any changes or determinations. But for right now, that should be unaffected. As to what will be taken over by the DOH and potentially be persisted or enacted in a different format, this is all relatively new. So there's kind of a scurry now of what this is going to mean for the long term. So we don't have great details as of yet, but we have reached out to our, I guess I'll say lobbyists, our representatives within the state to see what they intend or what they think the downshot of the sunsetting of the public health emergency would be. And then what potentially would be the trigger for the public health emergency being reinstated. So if we do see a surge, what might trigger that? I point that out because if you've been following the news, Governor Hochul instituted a state of emergency around polio, and there has been one confirmed case thus far. Now, there has been, if you look Rockland County and surrounding, there has been some wastewater finding of copies of polio virus. Nobody really knows what that means at this point. And those counties where they've seen the wastewater increase in viral load are counties that, for a multitude of reasons, have relatively low polio vaccination. So I point that out to say very low threshold to declare a state of emergency around polio, but fairly tall threshold, you may argue, for sunsetting the state of emergency for COVID. So this is going to continue to be a moving target and something we'll keep an eye on.
Hey, Chad, while you're on that topic, I just want to, Carolyn Cleary put a nice, smart question in the chat, which is the question about in-house COVID testing. co-pays or full payment now that might need to be assumed by the patient. And I don't think we know that for sure yet, but I wanted to just turn it back to you to see if you'd heard anything on it.
I have not heard that. That is definitely one of the pieces that's been brought up. And to my knowledge, that it's even a little bit messy because, as my understanding, some of the facilities are still using government provided COVID testing and reagents. So there's certain things that you wouldn't be able to bill for in that circumstance. So I don't think that is a given that would be a full share to the patient's insurance. Likewise, right now, for those who may have recently had cold or flu symptoms and went to the pharmacy to get a COVID test, if you have insurance, you can get it for free at most local pharmacies. Would that sunset for antigen testing available kind of free through the pharmacy? I don't think we know that either at this point. So there's a lot of unknowns with exactly what will change with this sunsetting. So definitely more to come, and we'll keep you updated as we hear more. With the discussion around the sunsetting and what the incidence is and how those two are related, I'm going to kind of transition into State of the Union because I think that will help inform some of the discussion around this bivalent vaccine that I know is going to be of interest. So right now, if you look across the Finger Lakes region, we're looking at about a 7.5. So I think the highest is 8.9% in Seneca County, rolling 7-day incidence rate. That is equal to, or maybe even slightly less than where we have been in the last couple of weeks. So we're still kind of holding in that low to moderate transition or incidence rate at this moment, which is great. One thing of interest, and I think this does get into the discussion of the bivalent vaccine. Up until this point, BA4 and BA5 subvariants of Omicron have largely dominated the positive variants that we're seeing in the population. So much so that one of the discussions are we haven't actually seen a lot of the genetic drift that we did before and new subvariants coming online. One thing that is interesting is that BA4.6, for those who are following at home and like naming things with numbers, has represented less than 2% of the incidence rate since late April, early May, when it came on the scene. On the West Coast, it has now jumped up to a little bit, about 2 to 3%, which is the first time it's kind of blipped on the radar. But if you go to the Midwest in Nebraska, Iowa, Colorado, it's as high as 17.2% of new cases. And for the first time, there's been a decrease in BA4, BA5. So why is that interesting? It may be that there is a new subvariant that is starting to take hold. And there is some concern, although not well reported yet, that BA4.6 may be somewhat elusive to existing vaccines, including the new bivalent. So that is something we'll have to keep an eye on, both because while it does not appear for everything I've read so far that BA4.6 is causing more severe infection, it is another that seems to be very easily transmitted. So we may see, whether I hate to call it a surge, but another blip, I will say, at least for right now, if that starts to take hold and if it seems to elude some of the existing protection, I guess I will say, conveyed by prior infection and or recent vaccine and booster. So I think for right now, certainly we're seeing, with school starting back up, with sports kind of getting fired up, the communities largely have, especially with the sunsetting of the state of emergency, the amount of masking requirements has diminished even on public transit and the like in New York City. So we are going to see the potential for exposure going up as we move into the winter months. At the same time, if you're following the incidence of influenza in the southern region, the suggestion would be that this actually may be a fairly severe flu season, and that potentially the influenza vaccine may not be the greatest protection at the moment. And one of the things we had talked about from the early days of COVID, before we had COVID vaccination, was would influenza actually compete and actually suppress the COVID incidence, or would there be this kind of super mixing where you would basically get COVID and flu simultaneously? I think it's at least to me, not very clear. If you look in the southern region, you're not seeing, I should say southern hemisphere, you're not seeing a huge spike in COVID incidents at this point. So, how much BA 4.6 or BA 6 will there be in the southern hemisphere? I don't know that. I don't track that. And I don't know if they're tracking that, to be quite honest. But I do think it's interesting to note that the influenza season looks like it could be significant this year. I will also note, and this is still quite a bit of disagreement, but the discussion around co-administration of COVID booster and flu vaccine. From a public health standpoint, there seems to be growing interest, if not outright recommendation, that while they are a captive audience, you give them both simultaneously. There is concern from an immunologic standpoint that co-administration of the vaccine may weaken the resulting immunologic or immunogenic response to either or both. So that obviously plays into the calculus. There is also the discussion that, flu vaccine, in fact, I was reading something this morning in anticipation of the call today, that the anticipated protection of the flu vaccine probably has about a 4-month window before it starts to wane. So if it's a late arriving flu season, as it was last year, getting the flu vaccine today at the same day that you would potentially get the bivalent booster may potentially lead to some waning of immunity towards the February timeframe if it were to spike like it did last year. Interesting, and honestly, this is the first time I'd ever seen it documented, and if others know differently, the waning is as much as 10% by 4 months after the flu vaccination is administered. 4 months, 10% per month after 4 months for flu vaccine. There's the normal waning of immunity, which I had never seen that documented, which was good. So, I think the CDC is recommending that everyone should receive their flu vaccine by the end of October. If everyone is not connected to Wegmans, they have been sending out text messages at a feverish pace that flu vaccine is now available. So the vaccine is available today. So I guess if you were probably optimizing and pursuing COVID bivalent vaccine, maybe you would do the COVID bivalent now and the flu closer to October. But I think, I think Dr. Fauci had recommended that it may not be unreasonable to consider co-administration from a general epidemiologic benefit, even if it wasn't necessarily the most protective for that individual person. So with that, I understand we have one of our ID friends here to talk about the vaccine booster, because I know people have questions about when they should get it, what they should recommend, what populations need it now, what populations can and should wait. And I'm trying to see if they are on.
Chad, I know Jenny Nyack was going to join. I did not see her jump on yet.
Okay.
So if she can give a big shout, as soon as she does, if you want, if we could do a little interval, I could do a couple of quick updates from my end, because I'd love to have people have the benefit of, Jenny's wisdom in this space and her expertise. So we're putting a pause on that for a second, folks, shifting gears for a minute. And really all of my updates are no new updates, but I just wanted to be able to touch base about them in that we have not heard any new updates or revisions to the healthcare worker bonus program. There's not been anything new released by the state in terms of their guidance or their FAQs since August 31st. And so I know the Monroe County Medical Society and MISNI legal teams continue to stay in contact with the state, and there will be further updates or, if needed, webinars that are held when that comes through. And then also just wanted to shift for a moment to let folks know that there also are not any new updates to sort of school guidance or to the cardiac assessment or return to play after COVID documents yet, but those should be coming. within, I would say, the next 2 weeks, the AAP is re-upping their recommendations. They will not give us a preview as to what that is, but I am hearing that it will be very much informed by what has been noted during the pandemic with regard to incidence of myocarditis or risk for that for kids with COVID. So we hope that that guidance will look a little bit more like what is actually happening, I think, throughout our region. We did put out information. Jana helped to release information from both Dr. Stephen Schultz and myself as we partnered, just to make sure folks were aware that almost all of the previous Monroe County Medical Society or Monroe County Department of Health, guidelines were now, no longer active. All of that information is available on our website. Everyone is really following the CDC and then the revised New York State DOH and joint guidance with the New York State. Sorry, I just had like a total blank on that. On the DOH guidance. I'm sorry, I'm getting interrupted by a call at the same time I'm talking, and it is related to my family. So I apologize. I'm gonna have to shut off my screen in a second. I'll finish my sentence. Basically, there's a lot of variation among the schools. That's the bottom line. You are all living it. And I think just at this point, just to continue to practice the way that we have been. And I see that Jenny just joined. So we're going to shift back to talking about the boosters. Thanks. Chad, do you want to give Jenny a little lead in since she just joined?
I shall indeed. So Dr. Nayak is one of our PEDS ID wonderlords and has a wealth of information and knowledge about the vaccine, and far better than we do. So just as a lead engineer, the questions that have come up recently are both, interval of vaccination based upon largely the questions I keep getting are for those who have had vaccine and booster and or recent infection. I know the initial guidance had been if you were 2 months out from last booster or 3 months from most recent infection, that population should consider receiving the vaccine. And the things that have been brought up are, too close interval of boosters. Does that suppress immunity? Does it decrease the immune response? Is it better to stretch it out? It's been brought up that for the Canadian Medical Epidemiologic Society, which I can't remember the name for, that they've actually recommended a 6-month interval, which is not necessarily directly in cahoots with the CDC recommendations. So any thoughts and guidance you have would be well appreciated.
Yeah, I do think this is an area, just to kind of speak to your questions initially, I do think this is an area where there is a lot of confusion. And honestly, the science is not that good in terms of what interval is too close, what interval is too far. I think the take-home point, at least in my brain, is that with the bivalent boosters, this is going to hopefully refocus immunity based on back to BA4 and BA5, which is what's currently circulating in our community. So in theory, those vaccines should boost antibodies more specifically to those two strains. So the concern for duration of immunity with inactivated vaccines, there's been talk that by boosting in too close of intervals, could there be neutralizing antibody that would impact the protein that's produced by the mRNA and ultimately decrease vaccine responses? At least so far, based on my understanding of immunology, that is a thought, but it's not exactly been proven. It has been proven with live attenuated vaccines, but that's not what we're dealing with here. As far as so when we're talking about the interval, I think the 2-month interval that CDC has endorsed for, based on our current knowledge is appropriate, because no, we don't want to boost these people on top of just giving them a booster. But at the same time, the point of the updated booster is to refocus that immune response. So not waiting 6 months when BA4 and BA5 are no longer circulating and we don't know what the viral strain that's going to be circulating is possibly. I mean, we don't know there's going to be a strain shift, but there could be. The 2-month interval in my mind makes sense. The other consideration with intervals is if you wait a longer interval, there's the thought that immune memory could be better. Again, here, we're not talking about one, like a 3-week interval or a 4-week interval as we did with the primary series. We're talking about 2 months. And it's not been shown that 2 months is better than 6 months. So I think in terms of increasing our antibodies to BA4, BA5, the 2-month interval makes a certain amount of sense. And there's not proven benefit to going longer. There's hypothetical, but not proven benefit. And in the setting of an updated booster, I think it's different than if we were just saying, let's give you the same thing we already have. Hopefully that makes sense. To comment on the kind of interval question a little bit further, hopefully there will be some clarity on that. There are clinical trials underway, especially with these younger age groups where, kids are coming in at 0 to 4, 2, 4, 6 months already, 9 months, 12 months for their well child checks. There are studies underway testing the 1 and 3 week interval currently recommended for Pfizer in infants against a more spread out interval that could potentially fit in better with the standard well child checks being done after 6 months. At 6 months and on. So that is something that is being looked at, and more data on that will be forthcoming. But for right now, for the infants, what's recommended is the 3-week interval, but the potential that could be spread out to 8 weeks with no harm for sure, followed by, for Pfizer, the second dose in at least 8 weeks. And I will say in the clinical trial, that interval, that 2-month interval between dose 2 and dose 3 for the primary series was hugely variable, with some of those kids being months out. So we don't think that a longer interval will in any way be harmful. The kids who were enrolled later all got 2 months. The kids who had been enrolled previously, some of them were 6, 7 months from their initial series.
And can you speak to the recommendation as far as co-administration with influenza vaccine versus staggered administration of those two?
My understanding is that co-administration with influenza vaccine is completely acceptable.
Very good. That was much more succinct than I was ever going to get. So any questions that folks have about that? I know that was a big download of information all at once.
And just so you know, in adults, at least, the co-administration with seasonal influenza vaccines has been studied, and similar levels of immunogenicity have been found. Overall, there has been one report that there might be some negative impact, but I think with kids, I think lately getting the vaccine in is the most important thing, and there's certainly not a substantial harm or benefit.
All right, I'm not seeing anything popping up in the chat or. Oh. Will we need a booster if we've had 2 vaccines and 2 boosters, and if so, when?
So this is for the adult situation, correct?
I think so, yes.
Yeah.
Okay. So, okay. So I think this is a difficult situation, and it does depend a little bit on is there any immunocompromise, and which boosters have been given, which boosters have been given when. In the setting of immunocompromise, I think the take-home point here in my mind as a PEDS ID person is that these are updated boosters. So it's not the same booster that has been given before. So, initially it's for people 12 years and older who are moderately or severely immunocompromised. The primary 2 series is recommended, then a second dose in at least 4 weeks, followed by the bivalent booster in at least 2 months. I would say that if you previously had received a monovalent booster dose, the bivalent booster dose can be administered at least 2 months after the last monovalent booster dose. And I don't know I have not precisely looked up this question, but my feeling would be that it's 2 months regardless of what booster dose you are on. And that goes for people who are immunocompetent, but greater than the, I think it was age 50 recommended. So for instance, my parents, I told them to go ahead and get the bivalent booster dose because they're more than 2 months after, despite the fact that they've had those previous 2 booster doses that were recommended for them.
Right.
I'm thinking of it as much more like, and this might help decrease some of the confusion out there, much more like an updated flu shot. So, if you got your flu shot late the previous year, yes, it was going to protect you for the tail end of the season, or the infants who require 2 doses, but that second dose is late based on their birthday. You don't not recommend the updated flu shot come the fall. Hopefully that makes some sense.
Perfect. Any other questions? I know that we only have Dr. Nyack for a period of time, so I want to give people a chance to ask questions before we.
No, I got my journal club out of the way now, so I'm okay. I did it beforehand.
Thank you, Jenny.
No
Yes.
problem.
LJ, did you have other things that you wanted to cover? No.
I did have one little thing. I want to apologize. As happens with many of you, you sometimes end up being the doctor for your family members. And so I just need to talk to my mother's doctor, and I apologize for sort of losing my train of thought for a second there. Thank you for your patience with me. I did want to the last reminder around school things. This is always, this is a great time of year for people as they send their kids off to school. This is the craziest time of year in many ways when you're in a pediatric or family medicine practice and you're needing to get every kid who didn't get in for their physical or for their immunizations. And I just wanted to remind folks that RCSD, for those of you that care for Rochester City School District children, they changed their process this year to be more efficient. And I'm putting this into the chat right now, but they have a centralized fax now. We released this information in an update back in July. We'll re-up it again. And thank you, Jana. Jana says we're going to include it again today. I got feedback from the head of nursing at RCSD that this system is working so well. So much better than the past, because sometimes the faxed physical forms were not making it to the nursing team, and so we're not getting inputted. So they were, going back with kids who already had their physical or who had their immunization. So it's allowing them as a team to really focus in on those who have not. You're likely to get outreach from families in the next 2 weeks, because the deadline will be coming up in 10 days. That for kids who do not have a required physical form or the required immunizations, they will be held out from school. This is something that happens every year, but we're moving forward much more efficiently and collaboratively on this than I think we ever have in the past. So that's good news. So just wanted for people to know that. That was it for me, Chad. Thanks.
Perfect. Jana or Renee, do you guys have anything? I think I've said my spiel.
I've got nothing.
Yeah.
All right, so we can open it up for general thoughts, questions, criticisms for LJ. All right, hearing none, we can give people 10 minutes of their life back.
Just Chad, real quick, to comment, you did mention, and I think I forgot to address the infection question. And I think just to briefly comment on when you should time the booster post-infection, it's not, the data here is not clear. I've been taking with my recommendations to people a more common sense approach to this. It's not required that you delay a primary series or a booster post-infection, but you can do that. And I think the one thing that we've found out so far is that, similar to seasonal coronaviruses, immunity to COVID-19 post-infection or vaccination is not particularly durable, especially with, borrowing from the influenza world, antigenic drift that occurs. So what I've been kind of telling people who ask me is it's very reasonable to delay, and the 3-month time period, to me, I wouldn't want to go right up against the 3-month time period because we certainly had infections as you approach that and even before that. But I've told people, delaying 2 months and then you'll get in before 3 months is very reasonable. You certainly could delay a full 3 months, but then I always worry about, okay, well, it's 3 months now, especially if there's some antigenic drift going on. Are those people going to be, susceptible to an infection that could have been prevented? But I think that a delay there, especially in the setting of an immune response that is not durable, is very reasonable.
Okay,
Does that make sense to everyone?
absolutely.
This is Osvig. Yesterday in the CDC's conference call on the COVID vaccines, they were recommending at least 30 days and preferably 3 months because the neutralizing antibody levels are greater if you wait until 3 to 4 months post-infection.
So that is certainly the ability of neutralizing antibodies to interfere with vaccine responses. I haven't seen the particular studies they're referencing there, I will say that. But certainly immune durability is well documented to be better the longer the interval is with multiple different vaccines. That's why we boost the way we do. I think that if it's a family, they'll get back their, pro-vaccine. I think that's very, very reasonable to wait. And like I said, I've been kind of routinely telling people to wait. You have to balance susceptibility to reinfection with the potential delay in immunity. And that's why I've been kind of saying, if you come back in the 2 to 3 months period, that's kind of the sweet spot. So we know we'll get you in. But I think that's essentially the same thing that you're saying, is that some delay might not be, will not do harm, especially when you consider the fact that very well we'll be sitting here the next year talking about updated boosters again. And we know based on, BA4, BA5 coming through on the coattails of significant BA1 spike, that immunity is not durable here.
Yep, right on. I think the other thing is what you said, that the CDC emphasized. The important thing is getting people in.
Yeah.
And so if you have them in hand, then doing the shots together, flu shot plus COVID shot plus that sort of thing is reasonable to do.
Yes. And I would certainly do that, because if you don't do them at the same time, you're going to risk losing them. And any loss of immunity, it's going to be subtle if it's even a real thing. And it's going to be a much greater loss of immunity if you don't get the shot in them at all. So
that's correct.
And I will put out there, because other people have asked this, and Jenny, if you know different, certainly pipe in. One of the questions is, are we just going to see another different formulated booster 2 or 3 months from now? And that this is going to be a thing, like every 8 weeks, there's going to be a new booster targeted against the circulating strain. I kind of preface the discussion, say, as of right now, that interesting, we have not seen the antigenic drift that we did before. So we haven't seen, like this BA6, 7, 8 on the horizon that are popping up in different areas, or yet a whole new virus altogether. But also, the more and more of the discussion seems to be on focusing on kind of annual boosters at this point, starting potentially with the bivalent vaccine. So
that's exactly the same thing that I have heard, both from, I'm involved in some of the clinical trials, both from the people who are doing the clinical trials, as well as from regulatory agencies, is similar to flu. Yes, we have antigenic drift during the year, but we can't keep updating the vaccine for that, but more looking at it annually. And that's what I've heard, is kind of the unofficial, what the companies are thinking of in terms of reformulating as well. And I think it makes a certain amount of sense. It's important to remember antigenic drift is really driven by immune pressure. With BA1, there was this humongous, tremendous spike of infections and a huge amount of immunity in a very short period of time. And we just haven't had that huge spike, thankfully, with BA5 yet. So we might not have, I think we will eventually see antigenic drift. I think it's inevitable, but I'm hoping that it will be slower as we kind of hopefully get to a more steady state of infections.
All right.
Nobody has a crystal ball though. And COVID has definitely proven that to us all.
Jenny, we appreciate your very practical and very clear thinking around this and translating all of it. It is really confusing, I think, for everyone. So thank you.
No problem. Hopefully that's helpful.
Very. All right. Any final questions for anybody? Otherwise, we'll give you 5 minutes of your life back.
Sorry.
No,
That was a good 5 minutes to lose.
that was a very good 5 minutes. All right, everybody. Have a lovely beginning of fall, if that's what we're in, or end of summer, however you look at it. And we'll see you back next month.